So I hope that question generated some good discussion, but I think I will, as I develop the case, I'll try and give you my take on it. And so my take on Sarah's current problem is best explained by her comments to the gastroenterologist that her pain is real but not functional. As you've hopefully gathered already, functional abdominal pain may not be coming from a disease, but it is certainly real. So the fact that Sarah thinks that the functional abdominal pain is imaginary means that somewhere along the line there's been a breakdown in the communication and the message around the diagnosis. Because Sarah is not imagining her pain, it makes perfect sense here that she should not accept a diagnosis of functional abdominal pain as she currently understands it. So unfortunately, the scenario described is quite common and naturally may play out just like this. So for example, when a patient believes that a doctor has misdiagnosed them, they often seek other opinions. And these new doctors that are often working in places where follow-up is challenging or sometimes impossible are put in a very difficult position. Any doctor meeting a young woman for the first time who is urgently seeking help for severe abdominal pain will justly be more focused on ensuring that the diagnosis of functional abdominal pain is correct. Because a big part of the diagnosis is looking for and excluding evidence of disease, the doctor is more likely to ask about symptoms of disease and order investigations. So it's definitely true that in some patients, investigations should be considered before a diagnosis of functional abdominal pain is made, because no one wants to miss a treatable disease. However, in other cases, a simple discussion and examination may be all that's needed to conclude that it is functional abdominal pain. It's normal to be worried when investigations are ordered, and if investigations are repeated, as in Sarah's case, it may actually reinforce a false belief of the patient within the patient that they have a disease that's going undetected. Once the tests are negative, the doctor then tells the patient that there's nothing physically wrong, which then reinforces the misunderstanding that functional abdominal pain is all in your head, which it is obviously not. So you can then see why it's common for patients in this situation to lose trust in one doctor, then consult a new doctor, where the cycle is unfortunately repeated. And in particular, in an urgent care setting like an emergency department, it's more likely for the focus of these visits to shift away from the real problem in most of these people, which is the functional impact of the pain. For all these reasons, I, like many others, believe that testing should be done on a case-by-case basis if functional abdominal pain is suspected. It's also usually best for one doctor to coordinate care, especially to ensure that no time is spent duplicating questioning and testing that is actually possibly counterproductive and will not help you get better. But functional abdominal pain is not imagined, it is a real illness, and that should be the take-home message.